Welcome to the Interventional Glaucoma podcast, brought to you by Elios. Join us for unscripted discussions about the latest innovations in interventional glaucoma with leading ophthalmologists in the field.
Hello everyone and welcome to the IG Interventional Glaucoma podcast. My name is Dan Linfield from the UK and I'm joined by two superstars of glaucoma from around Europe. Today we're going to talk about the importance of gonioscopy and how visualization is key to success in the eye procedures. My first guest is Nishani Amarasinghe from the UK. Hi Nishani.
Hi Dan, how are you?
Very good, thanks. You?
Yeah, fine, thank you.
Brilliant.
Thank you.
And thanks for coming. Thanks for giving your expert expertise on our podcast today. And secondly is my new friend in glaucoma, Caroline Medina Martin from Spain.
Hello, Dan. How are you?
Yeah, good. Thanks for joining us.
Good. Thank you very much for the invitation.
A pleasure, an absolute pleasure. So, gonioscopy, it is vital and underpins everything we do. Let's begin with the basics. Why do we think it's so important? Maybe Carolina first. What are your thoughts on gonioscopy for glaucoma?
Well, gonioscopy is the main issue in most of the glaucomas that we see every day. So I cannot imagine a glaucoma specialist or anyone who wants to start training in glaucoma not knowing or being very, very familiarized with all the structures of the angle, because this is the area which is going to create the problem and also the area that we are aiming to treat. So I think the most important thing is to be very, very familiarized with all the structures in gonioscopy.
I think you've hit the nail on the head straight away. So we're moving in towards a MIGS world for glaucoma, and many cataract surgeons are taking on MIGS as part of their armamentarium for glaucoma care. But I think you're right. Gonioscopy is vital, isn't it? It really is key to what we do. And there are differences between gonioscopy in the clinic on a slit lamp and gonioscopy in theatre, or the OR as it's called in many countries. Nish, what are your thoughts on the differences between OR and clinic gonio?
I agree. They are different techniques, but I think you do need to be comfortable with gonio on the slit lamp and just keep practicing that so that you know what normal is, first of all. With respect to gonioscopy on the under the microscope, in the slit lamp, you rely on the corneal wedge so that you know where Schwalbe's line is, and then you can work out the structures from there. You don't get the same corneal wedge in intraoperative gonioscopy. You need to know where Schlemm's canal is. And there are some little tips and tricks that we can do to see where Schlemm's canal is, either refluxing blood into it or using something like Vision Blue or Trypan Blue for angle visualizations. Sometimes you get those blonde angles, so using a dye to dye Schlemm's canal can tell you where exactly it is.
Yeah, it's a great tip, isn't it? So yeah, just talk us through that again. How do you apply Vision Blue or Trypan Blue?
Yeah, just as you would do normally. I usually do it actually under Helon, but you want to make sure that you are dyeing the Schlemm's canal, so you want to be directing it towards a trabecular meshwork under Helon. You can either and then wash it out and put in the Helon 5 to expand your AC.
Yeah, it's a brilliant tip, isn't it? And it stains, within 30 seconds, you've got a nice, basically a blue stripe, haven't you, to aim at? And it's the same for any MIGS device. Are there any concerns with a technology like a laser technology like Elios with Vision Blue? Does it change the uptake of the laser or anything in that regard?
To be honest, I'm not entirely sure, but I don't think it does. I haven't had any problems with it. I don't know whether you've had any experience, Dan.
Yeah, it's a cold non-thermal non-pigment adjusted laser, so there's no difference at all. So if you're thinking about argon laser, then coloration affects laser uptake, but for excimer, there's no difference at all. So you get the same energy to tissue, you get the same ablation regardless of coloration. So you're basically safe to use Trypan Blue. And then, Carolina, we talked about the kind of blood into Schlemm's canal reflux. Any tips on that? When do you see that most often, and how's that helpful to you?
Well, to me, usually you see it very, very often if you practice gonio surgery after the cataract surgery. So it's quite common to have the reflux straight away once you plan to do the the Elios or whatever intervention. So it's very helpful in the way that it allows you to see exactly where you're aiming towards, what you're aiming for. It can also be a disadvantage in the way that when you start with a Elios treatment, you might get some blood into the anterior chamber. This should never make us nervous. We will get a little bit more of viscoelastic, clean the blood, and keep on going as it is. This only means that we are in the right position and we're doing the impacts in the right structure. And it could be because we are losing a little bit of pressure in our anterior chamber, and that's all.
Yeah, it's perfect, isn't it? So yeah, anterior segment surgeons, cataract surgeons, we're all kind of scared of blood, aren't we? It's, we want a perfect bloodless phaco, and there's certainly some tips to think about for blood on the corneal surface. So we'll talk later about the nitty gritty of gonioscopy, but when you make your corneal incisions, they need to be really quite corneal. You need to avoid corneal blood vessels and limbal blood vessels, because if you get blood underneath your gonio lens, it really does cause trouble. It's hard to keep that clear, and a tiny bit of blood just spreads across the lens surface. But heme reflux from inside the eye is actually positive. We actually know that we're getting in the right place. As you say, there's nothing stopping you refilling the eye viscoelastic, pushing that blood away and trying again. But heme gives you that lovely red stripe across the angle, which you know you're going to aim at. Out of show of hands, really, who does their MIGS device, be it iStent, Elios, Hydrus, etc.? Who does that first before the phaco, and who does the phaco first and the device second? Nish?
So I do the phaco first. Usually when I'm operating on these patients, it's the cataract that's been the indication for the surgery, and we've offered the MIGS procedure as an extra, as a safe, effective way of maybe getting them off the drops or improving their ocular surface, whatever the indication is. So because cataract surgery is the main indication, I usually do that first and then get on with the MIGS procedure. I know some people do it the other way around, but I haven't had any problems with the view or looking at the angle by doing the cataract surgery first, so I've stuck to that at the moment.
Okay, so Nish phaco first. Carolina, are you phaco?
Yes, I am phaco first as well. There's two reasons. I know some colleagues of mine also are starting to do it the other way around, and I think it's a very good idea in some cases. But in our clinic, as what Nish said, first we do the phaco, and usually the laser is an accessory to the surgery. But in some cases where we are starting to put patients for cataract surgery, when we see a little bit of a narrow angle that can open with the phaco. So usually we do the phaco first. If the angle's opened completely or enough, we will do the laser treatment. And this is one of the reasons why I think phaco should be done first in those cases always.
Yeah, interesting. I think I'm a bit of an outlier here. So I used to do a phaco first, and my fears were, get the lens out, get that safety bit done first, and as you say, open the angle. But I have switched around, and I've not really looked back. My argument was actually, when you're assessing an angle in clinic or on ACD, anterior chamber depth on biometry, it's this is a fluid filled eye. Once you pump some high viscosity viscoelastic in, you're probably going to add 50% to that anterior chamber depth already. So even a 2.2 millimeter ACD suddenly becomes more than 3, and you can see meshwork in nearly everybody. It's only PAS that stops you seeing it. But I like the way that you just get a perfectly clear cornea. You make your incisions for the MIGS part, be that Hydrus, iStent, whatever. You put your incisions in the right place for the MIGS device, because that's often the hardest bit for most of us. Even though we do high volume, it's still much less than our cataract volume over our careers. And the cornea is pristine, utterly pristine. You don't get that sort of bouncing and the manipulation that gives you some corneal striae and changes throughout the time. You don't get as much blood reflux that way. So because you're going straight in, without the phaco vacuum and highs and lows in pressure, you get less blood reflex through Schlemm's canal, which makes visualization harder, but you then get less blood reflex later, and your heme rates post-op and inflammation rates post-op seem to be a little bit lower. I also... Sorry.
Yes, sorry. Dan, just one question, because you are obviously a high expertise glaucoma surgeon, but when you have your trainees, do you let them do the gonio first after, and then the cataract, or
Yeah, it
do
depends what
you?
we're going to do actually. So, if the trainee's learning MIGS, I don't mind which way round we go. I probably, if I'm worried about the phaco, yeah, that's the time when you maybe do the phaco yourself first and hand over for the MIGS. If you've got a trainee surgeon doing the MIGS part only, then I don't think it matters. Almost, it's better to have a nice view for them, really, because they really can put their incision where they want their injector or laser probe to go. It seems to just change it by a few degrees, especially with something like Hydrus, where we're quite a long way around. But no, I think it also allows you to fully remove we're all using Helon GV or similar, but something more cohesive than we are for cataract surgery. And I find with my little tiny skinny IA irrigation aspiration handpieces that it often gets clogged, and it's really difficult to get all that viscoelastic out at the end of the case. Whereas if you do that at the beginning of the case, you've then got the phaco tip in the eye to remove the lens. You can guarantee that all viscoelastic has gone. Makes it much easier that way. But yeah, it's worth thinking about. I think there's no definite gospel right or wrong, but it's nice to know that you've got options there. And I think we'll evolve that along the way.
Can I ask, Dan, would you, so for, let's say, not for trainees, but as a cataract surgeon starting out with MIGS, would you recommend doing it this way around then?
Yeah, I don't know. I think so, but I guess the reason being is if you're going to have a complication during your cataract, say you got an AC tear or zoniodialysis or dare I say a PC rupture, that happens rarely, but if they occur, you then are probably duty bound not to perform the MIGS device, aren't you? I don't think anyone's going to start popping stents or laser in when you've got, unstable lenses of vitreous in the way. I think if you did the MIGS device first, whatever happens during the phaco, and luckily in our lives it's rarity, but you then got that device on board already, and these are the patients that are going to have trouble, especially if they've got glaucoma. You really don't want the difficulties post-op with spikes and et cetera, et cetera. So I'm always thinking that it's almost safer to do it first because you're going to get it done whatever happens. But yeah, you can argue that both ways, and I don't think there's a right way. But I definitely find that you just get a better view doing the MIGS device first, and it's just worth a try for everyone, really.
Yeah, definitely.
I think it's important to control both.
Yes, exactly.
And adapt to the case, adapt to the patient, and adapt to the person. The surgeon should adapt to the situation. I think that's the best way. Yeah.
And like we've already talked about today, there's patients who the first intention is the cataract component, and the MIGS device is a secondary addition, and there's patients who we're really doing it for a glaucoma indication, and the cataract is almost a secondary indication. So I think that's how you can balance it and justify which one's first and which one's the secondary. Gonio lenses. So getting a bit geeky on details of gonio lenses. What do you both use in the OR?
I use the Catena lens, which is a disposable lens. I mean, I think you probably get better optics with a non-disposable lens, but it is very difficult for us in the NHS to have enough of those with a turnaround time to sterilize them. So I use the Catena. I stick with one lens because I'm comfortable with it. I am trying other lenses. There are some hands-free lenses around. I have to admit, I think I use my non-dominant hand, my left hand, to slightly use the gonio lens to do my very fine focusing and last bit of feedback regarding where the trabecular meshwork is. So I find the hands-free not as easy to use, but I don't think that's I think that's something that would just come with practice if you are using a hands-free lens. But I'm quite happy with the Catena lens.
Right.
I usually use the Swan Jacobs lens. We also have an ACMED lens, but we use it only for very fine specific cases. For example, patients who have neck problems or are not able to turn the head. Very, very specific cases because they're little treasure. Yes. And I've also tried the hands-free lenses, and like Nish said, I also use my non-dominant hand. I kind of help myself to tilt the eye with the lens itself, when I think the hands-free lenses are going to come our way, and we are going to get used to them, and they're going to be very useful. But they are non-dominant hand for any surgeon who uses bimanuality, which I think is very, very important. The left hand is always there, even if it's just for help or to tilt or to do something about it. And if with the hands-free lens, everything depends 100% on the microscope position and the patient's position. With your left hand, you can help yourself a little bit, I think, but I don't know if you've had any experience.
Yeah, I think that's a good summary, actually. So the hands-free lens assumes that the phaco is a non-dynamic, so the gonio lens is a non-dynamic, just a viewing piece. You just pop it on the cornea and it's doing its job. And it can be if the patient's in a perfect position and the microscope is, but I think it's a dynamic search. You're constantly rolling, twisting, pushing, pulling. You're doing something to get that view perfect. And it's probably subconsciously. That's why I think it's hard to train in the first few cases for trainees. But the left hand is definitely doing more than just plonking a lens on top and leaving it. I think you've both summarized that. I'm left-handed, so I phaco right-handed because that's how I was taught and had to be taught. My first few consultants refused to let me do a left-handed phaco. So I quite like using my left hand to chop and to put gonio lenses on. But I think that left hand is constantly dancing and doing things that it could do. I like the two-handed idea because, as you know, I do my Elios shots wide. I deliberately try and spread them really, really wide. So having a left hand in and a right hand in would be brilliant for that. But I tend to just move the microscope round to let me do that. But yeah, Catena lens is basically a disposable Swan Jacob, isn't it? It's a single use. It's approximately 10 euros ish per lens, and I'm the same as Nish. That in the UK, Swan Jacob is expensive and autoclavable, and often doesn't come back in time. So we have a box of single use prisms, which are often bundled with the devices as well, which is quite nice. Has anyone used a lens with a mirror that allows you to just be upright rather than having to tilt the microscope? Has anyone used a sort of top-down mirrored lens for MIGS?
Yes, sorry, Nish, you first.
No, go on, Carolina, because I haven't, but the Ahmed isn't it?
Yes, we've used the Ahmed. I said I've only used it a couple of times, and because it's, as I said, is the most guarded treasure of my hospital and my unit. So we used it we don't use it very often. And it's true that everything is the other way around. You need to change your brain to use it. The first time you try to do a procedure with the lens, you might be a little bit confused. But I think for a person who has done this type of procedures quite often, it's quite easy to click left is right, right is left, and up is down. That's it.
Yeah, it's quite a confusing way of working. There's single mirrored upright lenses where left is right and right is left, and then you can get double mirrored lenses too, which then take them back to the right way round. The more mirrors you add, the more image degradation you get. But the idea of being straight down on the cornea, rotatable. So if you're doing a kind of canaloplasty, you can just twist it and watch it go round. So that's quite beautiful. But once you start adding mirrors to the optics, you do lose the view. Yeah, perfect. Let's talk about targets. So once we're in the angle, so be it cataract's already out or you've gone straight for the device, you're looking at trabecular meshwork, which you've either used your super skills to identify, or you put vision blue in, or there's some nice blood reflux. How do you then think to get your Elios shots in the right place? What's your mentality once you're sitting there with a iStent or a Hydrus or an Elios in the angle? What are you aiming for? Carolina first, go for it.
Okay. Well, usually we know this goes back to our basics. You need to know the structure of this Lomb canal. You need to know exactly how this Lomb canal is settled in the angle, and so because of that, I usually aim for the most anterior part of the pigmented meshwork. So I usually aim for that. I know I'm 100% going to be in the right position. If I'm using an Elios, usually the Elios has this perfect size to cover the whole canal. And so if you aim for the lower tip of the Elios, for them to touch the middle or nearly lower part of the pigmented meshwork, you're in the right position because it covers all the way up the whole canal. I don't know if that.
Perfect. And Nish, any thoughts from you?
Yeah, I agree with Carolina. Yeah, basically, what you're doing is trying to aim higher and the higher part of the trabecular meshwork, because you've got to overcome parallax. You're going to get parallax from lots of different ways, from your gonio lens, from where your incision is, and so if you aim for the anterior part of the trabecular meshwork, but think of aiming a little bit higher, you're usually in the right spot then.
Yeah, perfect. It's a subject that really needs us to have some pictures, isn't it? Because I'm sure we're all sat here waving our hands around trying to point to things.
Yes.
But we can probably link in the show notes to we wrote an article about the Meigs parallax effect, but basically this theory that you're always coming from almost a corneal apex or a high corneal incision heading down towards trabecular meshwork, and that Schlemm's canal is behind trabecular meshwork. So if you aim at Schlemm's thinking you're going to aim at trabecular meshwork thinking the Schlemm's is directly behind you, you're going to miss it on the low side. You have to aim above the target, because by the time you keep this angle going down from your higher view, you need to allow for that parallax. But yeah, it needs pictures, and if we can pop some show notes to that article, I think that hopefully illustrates it better. What I'd advocate is, having just done it as well with my just recently departed trainee, is to draw a map for your first few cases. So finish the case, and then in the operating notes, actually draw trabecular meshwork and put 10 dots on where you think each shot went. Maybe like a dentist calling out your teeth as you're going round, but saying, I thought that was perfect. Maybe that was a little bit high. That might have been a bit high, but slipped down as I took away the tissue, etc., etc. And then when you get back to the clinic, maybe a month later, don't do it too soon, have a look with gonioscopy in the clear light of day with a corneal light wedge and see where they all are. And I can pretty much guarantee that most of them are either on the right place or low. I reckon you're probably very rarely ever going to have a shot that's too high, it's too corneal. Yeah. We've just recorded some gonio video in clinic, and 3 out of 10 of our trainees first go were on target, and 7 out of 10 were low. Not a single one was high, and that's despite me in their ear saying, "Come on, aim high, aim high, aim high," and we're still not high enough for a lot of the shots.
Yeah, I think that's a really good tip, actually, really good training tip.
Yes.
Cool. I guess what happens if you're in the eye and you've done your phaco first and you think this angle looks a bit strange? You've not detected it at the pre-op. I guess it emphasizes the importance of a good pre-op gonio. And I think maybe one of our tips today is gonio everyone before they get to the OR, or trust somebody to do it properly. But sometimes you do take the lens out and go, "Oh, this looks a bit different." What are your thoughts there, Nish, about what you do?
I might just use some more viscoelastic to open up the angle a bit more, see whether there's just to have a really good view of the angle. I'm already on high mag, so I should be able to be, I should have a good view. If it's looking very abnormal, or there's lots of PAS there, I probably wouldn't do anything. Or with the beauty with the Elios is that you don't have to do all 10 shots, or you can direct them into areas that you think are more normal.
Yeah, good point.
And maybe put a few shots in, but areas of complete abnormality, I wouldn't be going into that area, I don't think.
Yeah, I have to agree. I think we feel duty bound to do something, and like you say, if it looks normal, I think you can treat. But if it looks screamingly abnormal, I think the discretion is key here. That treat where you can, but you don't have to put all 10 shots in, or you don't have to put a hydrus in. You can just do the phaco, which we know has a significant effect on pressure anyway. But I think Meigs works best in, as per licensing, open angle glaucoma. And once we've got angles that look a bit iffy, I think we need to be cautious with it. It may give you the result you want. It may not. And I think it just goes back to these patients. Every patient should have a really good pre-op gonio before they get listed for a device.
And I do think the surgeon should know the angle pre-op, and so if the patient, if the patient's been listed from some other clinic or something, then I'd still think you need to gonio them just before the ward round, just before the operating. You really don't want any surprises in theatre.
Brilliant. Anyone had
Yes,
any
I agree.
experience with sort of microscope adjuncts? Anyone used any 3D technology or birefringence or OCT? Anyone got any gadgets to help them implant MIGS devices?
I've used Ingenuity and that 3D system to implant MIGS devices, and the Ingenuity 1.5 has actually got a MIGS setting on it, which actually is really, really good. The problem with the Ingenuity is that obviously you have to switch sides and switch the whole system around for whichever eye you're operating on, because I do most of my MIGS temporally, so you can't set it all up at the bottom of the patient. You'd have to switch it from left to right eye. So that takes a lot of theatre time, but the actual optics and visualization that you get is really good.
I have a 3D microscope and an intraoperative OCT. For me, they are, well, the 3D microscope is very helpful for teaching or when you have somebody in the theater. But for me, at the moment, I can say that they are very nice toys for MIGS. They're very interesting, but they don't add any value at the moment for me to the surgery itself. The OCT is very nice to see where you put either the implant or the shots. You can kind of guess where they are with the OCT, and it's very fun, but it's already implanted. It does not add anything. You're not using it for the implant itself. I do use it for other type of glaucoma surgeries, but not for the stent itself.
It's just an expensive way.
Yes.
Expensive way of saying you've missed the target and you need to do it again. I think it's refreshing.
You already know everything.
I think it's refreshing that we all talk as human beings. There's a mentality that surgeons are perfect, and we obviously try to be, and our devices help us to get better. But I think we have to be humble and honest to say that, anatomy is variable, patients are variable, and we are variable, and devices are variable. There's so many variables there that we have to admit we probably don't hit the target every single time, despite wanting to. And that's why I think devices that have more than one shot, more than one option are useful. You've seen, trabecular meshwork bypass stents go from 2 to 3. Elios gives us 10 opportunities to hit the meshwork. And other devices, you see it slide in and you get some visual confirmation that you're in the right place. So I think we're moving towards that sort of confirmation from MIGS, which is lovely. And that's during the procedure rather than waiting till post-op to find out. And I think that's helping us get better results for our patients. We are more consistently hitting the sweet spot, and we are more consistently getting the pressures and medication lowered. Our data is tighter. We can be more confident that we're going to get the result that we hoped for and that the research suggests that we should be getting. Thank you. Right. Any final tips before we all close up? Any final pearls to let our audience know?
I think maybe we can round up some tips for anyone who's starting with gonioscopy surgery. I don't know if you think that would be a good idea at the end. Because obviously some trainees, we have trainees who are starting with cataract as well as gonio surgery. But as Nish said, there's a lot of cataract surgeons who maybe want to go into the field of glaucoma or want to tip their toe into the field of the glaucoma or glaucoma intervention. And this is very important because glaucoma is becoming more and more interventionist each time. So every time we are acting more on the angle itself, and we are targeting what the problem itself. So I think that what I would recommend is the first step is to be very familiarized with the angle. Nish once said that there was I don't remember, there was a surgeon or a doctor in Singapore who made their students do 500 gonioscopies before they could go into the OR. I don't know if this, do you remember that, Nish? You commented this once a long time.
Fellowship, you had to do 500 gonioscopies just so that you knew what normal was.
Yes.
they were gonio, residents would gonio everyone. And I think getting comfortable with what normal is quite important, because normal varies with from patient to patient. So I would say to trainees or anyone starting out, just make gonio part of your normal examination. It would have to be there anyway for the glaucoma patients, but in eye casualty, general clinics, gonio all the patients, and you can see what their angles all look like, and that will make you comfortable in the angle. Once you're comfortable in the angle, then you can first of all identify what normal is, then identify what abnormal is, and also be able to operate in it once you've got into the intraoperative scenario. And I think, again, because there is a slight difference between surgical gonioscopy and slit lamp gonioscopy, when you're carrying out your cataract surgery, just get used to tilting the patient's head, tilting the microscope, getting a good gonio view on patients that don't require MIGS. So at the end of your cataract surgery, you could just say that you're going to have a look at the angle, explain to the patient what you're doing, have a try at intraoperative gonioscopy, just so that you are used to seeing what the angle is like before you have to start thinking about inserting the MIGS as well.
Yes, and as Nish said, to practice with the gonio lens, even if it's in healthy patients inside the OR, because when you have the gonio lens and you're holding it, sometimes it's very difficult to have a clear view, and it has nothing to do with the microscope or the patient. Sometimes you're the only one to blame, because you're either pressing too much with the lens, or you're not holding it properly. And when you have to add this to your stress of initiating a new procedure that maybe you've never tried before, then everything becomes more difficult, and you're likely to go with a different mindset into the procedure itself. So I think if you're very comfortable with I see that in my trainees, when they start with the gonio lens and they press too much and they can't see, they get nervous, and they try to aim for the angle. And I'm like, no, first be comfortable, then sit comfortable, be comfortable with the patient. If you need to move the patient, then put the lens. If you're comfortable with the position and you can hold their hands where they are, because they need to be floating, then you go to the next step. Maybe you don't need to go straight away for the angle with the device. Maybe you can start with a spatula and try to aim for the not touch, but aim, like point at the different structures, so that you know where you're at any moment. And then when you're comfortable in that situation, in that scenario, then go ahead with the device, because that's what's going to give you confidence, and it's going to allow you to do a very good procedure.
Oh, I think that's a lovely summary. So you said the word confidence at the end, which I think is a great thing. It's about confidence, isn't it? It's taking away the pressure of having a device in your hand and just looking at the angle with no pressure. And that's the biggest two tips is your left hand has to float, almost pull up against that kind of viscoelastic on the cornea, that coupling edge, and you almost need to kind of lift it sometimes and roll it back. And the biggest failings I often see of first few cases are too heavy a hand on the left side, too much pressure on the gonio, and or not enough viscoelastic in the anterior chamber. And those together just lose your view. So lovely summary. Thank you so much, both of you. A final shout out to a website called gonioscopy.org. It is a not-for-profit, colleague-driven website with some beautiful videos and pictures, and it really is a masterclass in gonioscopy. So if anyone's not found that yet, I'd implore them to have a look, because that's how I've learned, and it's a beautiful website. So it remains me to say thank you to both of you. So Carolina and Nishani, thank you for being friends in my glaucoma journey and helping us along the way, and for giving us such great tips to our listeners. Thank you both for your time today, and thanks to Elios for hosting us.
Thank you very much, both of us. Both of you.
Thanks all.
Thank you for tuning into this episode of Interventional Glaucoma. Want to hear more? Be sure to click the subscribe button to be notified of new episodes. Please refer to the show notes for a QR code to access Professor Dan Linfield's article on the topic, and for more information about gonioscopy and the MIGS parallax. The Elios system Bausch & Lomb is manufactured by MLase GmbH and by WEINERT Fibre Optics GmbH. Elios is CE marked for use in adult patients with glaucoma and is currently under investigational use in the US as part of an ongoing IDE study by the FDA. The ExTra 2 Laser Class 4 has the brand name Elios. The ExTra 2 is equivalent to ExTra and AIDA devices. Please refer to the full disclaimer in the show notes.